welcome to this panel discussion on the role of genomic testing in prostate cancer. I'm joined by an international panel. Many of you will know this group. First is Derya Tilki from Germany.
Thank you for the invitation to this panel. I'm from the Martini-Klinik Prostate Cancer Center in Hamburg.
Thank you. Also with us is Prof Wyatt.
Hi, Professor Cornford and everybody else. Thank you for the invitation. Yes, as you said, my name is Dr. Wyatt. I am a scientist based in Vancouver, Canada at the Vancouver Prostate Center. And my background is in genomic testing for prostate cancer.
And last but not least is Joaquim from Spain.
Yes, thank you. Hello, everyone, and thank you for inviting me. I'm Joaquim Mateo. I'm a medical oncologist and physician scientist at the Vall Institute of Oncology in Barcelona.
And perhaps, Joaquim, you could start with a summary of why genetic testing has become important for prostate cancer.
Well, certainly. I think that there is an increasing recognition that prostate cancer is not only one disease, but it's a group of diseases where patients with different genetic backgrounds in their tumors can have more or less aggressive courses of the disease. So that's important. But in particular, in the recent years, it has become relevant, the identification of certain mutations in a list of genes called homologous recombination-related genes that are in charge of repairing the damage to the DNA, because we know that some of these patients that have mutations in these genes can specifically respond to a targeted treatment called PARPi inhibitors, and we have the data for olaparib from the PROfound trial that is approved in Europe and the US and many countries around the world. And there is also a second PARPi inhibitor, rucaparib, that is also approved in the US based on the Triton trial. So we can still discuss about which genes do we include in the list, how many patients does it represent, but what is clear is that there is a subset of patients who merit a different treatment strategy, and that this is identified through genetic testing.
And Derya, who do you think should be tested in the clinic?
Yeah, so there are different guidelines on the question which men qualify for testing. The broadest are the North American NCCN guidelines. They basically recommend testing in every patient, very low to high risk if they have a family history of prostate cancer, and also in all patients with high-risk disease and metastatic prostate cancer. The definition for family history in that case is a brother or father or multiple family members who were diagnosed with prostate cancer at a young age, meaning below 60, or also 3 or more cancers on the same side of family, especially if they have been diagnosed at very young age, below 50, and also including other cancer types, such as breast cancer or pancreatic cancer. Also, since this year, the EAU guidelines have implemented some recommendations on germline testing. They recommend it in all patients with metastatic prostate cancer, but also in patients with high-risk prostate cancer who have a family member, again, diagnosed with prostate cancer at younger age, below 60. So by now, most national and international guidelines have implemented these recommendations on germline testing.
And you and I both sit on the European Guidelines panel. We didn't go for quite such a broad range as the NCCN, but we did elect to advise for all men presenting with metastatic disease rather than waiting for castrate-resistant disease to develop. Can you help explain why that was the case?
Yes, so The reason is the implication, as we heard also from Dr. Mateo, on the treatment options. These are most relevant in the patients with metastatic disease, and also the frequency of germline mutations are much higher in patients with metastatic disease. Most publications have shown a rate of about 12% in metastatic disease, while it's only about 5% in localized disease.
And Joaquim, in a practical sense, what's the advantage of going for slightly earlier diagnosis of these genetic abnormalities?
Well, it is true that when it comes to testing the tumor for genetic abnormalities, the indication of treatment will not change by testing earlier, because at the end, these drugs are approved in the setting of castration-resistant prostate cancer and after progression to at least one novel hormonal treatment. But on the one side, having the information earlier can help us as physicians plan for our patients ahead on whether the patient would benefit at some point from this treatment. But very importantly, as Dr. Tilki was saying, there is a germline component to all this. So part of these mutations are going to be inherited. And most importantly, there is the possibility that this can be passed over to descendants. So identification of these mutations can also trigger the identification of families that may merit further testing or specific screening programs for prostate cancer or other cancers.
And if we do a test, do we always get a result first time?
Well, I think that if we do germline testing, so looking at normal cells for inherited mutations, is pretty straightforward that most of the times you're going to get a result back. But it is true that when you test a tumor sample, there are some technical challenges, particularly when it comes to the small prostate biopsies that we take at diagnosis of many of our patients. And there is a chance that sometimes the result from the lab will come back as non-evaluable, either because there was not enough representation of the tumor in the sample, or just because this sample had been in the pathology facility for years and years, and the DNA, that is what we look for the mutations in, has degraded over time. And this happens, it depends on the specifics of the technology, but on the PROfound trial, that is one of the largest efforts so far conducted in an international trial, it was in up to 30% of the cases where we had a first inconclusive result from tumor testing.
Perhaps I could bring in Alex here. Could you just explain the difference between tumor testing and germline testing for us?
Yes, of course. So as everybody's enunciated so far, there are both a germline component and a tumor-only component to the alterations we find. So for example, if we look at BRCA2, about half of the mutations we identify in BRCA2 will be germline in origin, and about half will be tumor-only. So a germline mutation is something that's inherited from a parent. So it's actually present in all the cells in your body. And what happens in the tumor is you get a second alteration affecting that gene. Whereas a tumor-only alteration is present by definition just in the tumor. And so we use the term somatic sometimes for that. So one of the challenges is that when we just test tumor tissue, a lot of those tests don't necessarily tell us on the origin of a mutation. It just tells you that a mutation is present in that patient's tissue. And so that's why it's actually normally recommended that if that test did not report or did not discriminate somatic versus germline, then you need to do some kind of follow-up test to work out if that was a germline mutation in origin. And the reason this is important is because a germline mutation in BRCA2 has familial cancer implications. And so it's really important to work out if other family members of that individual might also carry that mutation and therefore potentially be at risk of other cancers.
And it is BRCA2 that is the most common in prostate cancer of these genes.
Yeah, that's right. So there are actually lots of genes that can be altered in metastatic prostate cancer and lots within the pathway that is related to DNA repair. But of all of those genes, BRCA2 is the most commonly affected and is really the one we know the most about. It's a very well studied gene, partly because of BRCA1 in breast and ovarian cancer. And so it's the one where we have the most evidence from a treatment response point of view in the context of a PARP inhibitor as well.
Okay. Now, Derya, these patients are going to be found to have germline mutations. Who explains those results to them in Germany?
Yeah, so in Germany, it's the geneticists the genetic counselors who they would be actually sent to before testing, and then they would test and explain to the patient. So that's usually as I said, the geneticist. And in Germany, it's not that common. I mean, it's coming, but not that common to do germline testing as it's in the US. So there are still enough counselors available. But hearing from my colleagues in the US, there are by now a lot of urologists who have taken over that part, that they also do the counseling and explain it to patients and family members.
In the UK, it's a very similar situation. At the moment, the demand for testing isn't such that it overruns the system, and largely genetic counsellors support our patients when we have testing in the UK. But it is clear that if we test all the metastatic men, and if we get further and go along the American line and test all the people with high risk disease, we're certainly going to overwhelm the system, and we'll need to think as providers about how we support patients through the process. So Derya, what do you think that counselling should include for these patients?
Yeah, so there are different elements of informed consent for the patients, which really should include a variety of points, such as to explain the purpose of germline testing, also the potential types of results, such as variants of unknown significance, also the possibility of uncovering hereditary cancer syndromes, such as Alex alluded to also uncover additional cancer risks, to talk about before testing the panel options. I think we will get to that. Also to talk about consequences for other family members, and issues regarding data sharing, for example, privacy of genetic tests, and also laws that address genetic discrimination.
And Joaquim, you probably have as much experience as anybody about testing patients. How does this work in practice?
I can think of a few names that have much more experience than me, but thank you. I mean, again, we should differentiate germline testing for hereditary mutations and tumor testing. And when it comes to tumor testing, that is what we probably will become the newest standard in the coming years, at least for metastatic prostate cancer. I think that the scenario may be a bit different, because I don't think it's realistic to think we're going to have the resources to provide special counseling by a specialized geneticist to every single patient. At least not everything in the tumor testing is going to be about hereditary mutation, but it's about many other tumor features that we may be interested in. So I think that we as physicians, oncologists, urologists, and many other specialties involved are going to have to be trained in providing the patient the minimum information necessary to conduct the testing, and then to be surrounded by the necessary resources in the multidisciplinary team to help us interpret the result before we go back to the patient and discuss the implication of the results with that patient. So I think that it will rely more on the practicing physician, but with the support of other colleagues in the multidisciplinary team.
And do you think that we will separate out so that the physicians will do tumour testing, and only when that is positive will we then offer germline testing. Is that the way that this is likely to pan out going forward?
This is the way we have moved forward as the standard in our site. For patients with metastatic prostate cancer, for patients with non-metastatic prostate cancer, we are prioritizing germline testing, and then they go through a different route. But if tumor testing is going to happen, then it probably makes sense to wait until the results and refer for germline testing those with a mutation in the tumor that may potentially be germline. I guess the discussion may be that there is a possibility that the tumor testing may miss some mutations, right? So still that's for discussion, but I think that it will be reasonable to consider that if you have a patient with a very strong family history, even if you don't find anything in the tumor testing, there is a good reason to refer that patient for germline testing consideration.
Alex, is it likely that we'll find a germline mutation if their tumor is negative? What's the chance?
Yeah, I think that's a question a lot of people are asking. So if you do tumor testing and you don't find anything, should you be following up with other rounds of tests? The probability is quite low, very low actually, that you would find anything on subsequent testing. The key is if the tumor testing actually worked or not. So as Dr. Mateo mentioned earlier, the failure rate, attrition rate with tumor testing can be quite high. So I think when you're looking at the report, the first thing you should try to understand is, did this test work? And so sometimes you might get a result of sample insufficiency or test fail, and that's going to indicate that you should do another round of testing. But I think if tumor testing worked and you have a negative result, then no, you shouldn't be reflexing to a germline test. However, as Dr. Mateo mentioned, this doesn't obviate the relevance of a strong family history, and so hereditary counsellors have a lot more tools, to their hands than just a gene panel test. So those patients should still be referred onwards to geneticists.
Okay, we've touched a little bit on a negative test. We have talked about tumour testing, but we've not really discussed very much about what we mean by tumour testing.
Yeah, I think that's an interesting point, because we have really multiple sources of tumour for testing, especially in a patient with metastatic disease. I think in an ideal scenario, we'd collect a fresh metastatic sample. So if that's at all possible in a patient, I think that should be the gold standard. But the reality, of course, especially if we're testing men in the hormone sensitive space, is you don't necessarily have a lesion to biopsy, a lesion that's accessible, and it's also expensive and morbid morbid inducing to do that. So a lot of us have reflexed and ended up using what we call archival tissue, which in most times is actually the diagnostic block, the diagnostic tissue that was used at the very early stage when that man was first diagnosed with prostate cancer. So this is often stored, in hospitals and clinics around the country, and can be retrieved via request. And I think this actually gets back to a point that you made earlier in the discussion. Why are we testing earlier in disease stage? Why don't we wait until a man has hormone-resistant, castrate-resistant disease to test? And actually, you need to give yourself time for these processes to happen. If you need to request diagnostic tissue from a hospital in a different part of the country, and then subject that to undergoing testing, you really need to give yourself a runway in case that testing process is not quick.
Thank you very much. What happens, we've heard about circulating DNA. Is that an alternative? Would that be easier than doing a biopsy?
So plasma circulating tumour DNA is another option for identifying both somatic and germline mutations in any genes, really, but particularly for BRCA2, I think it has high relevance. The challenge is it's an emerging technology, so there are not that many tests around that can really leverage it. The timing of blood collection is also of critical importance. So there's actually only certain times during a patient's disease course that they have really detectable tumor DNA in the blood. So that's normally at time of clinical progression. So if you take a man at time of developing castration resistance, you have a good chance of that test working. But if you test while a man is receiving hormone therapy and responding, then those individuals are not going to have a sort of successful test. We shouldn't be thinking about this as a sort of solution to the woes of tissue testing. It's another weapon in the arsenal, right? It also has a failure rate, but I certainly think that it should be up there as an option for testing.
Thank you very much. I want to draw this to a conclusion, and before I do that, I would just like to talk, if Derya could talk to us a little bit about family testing and the implication for men earlier in the disease. We spent a long time talking about metastatic disease. So what's the implication for men presenting either with localized disease or the families of men presenting earlier?
Yeah, so in men who are mutation carriers but don't have a prostate cancer diagnosis, this is important for screening. There's, for example, the impact study from the UK, which has shown the importance of intensified screening in this population. This was a study where participants underwent PSA screening annually. And if PSA was above 3, they were offered a biopsy. So in this study, which was recently published in European Urology, after 3 years of screening, compared with the non-carriers, the BRCA2 mutation carriers were associated with a higher incidence of prostate cancer, also younger age of diagnosis, and more clinically significant disease. So this is the implication for patients or for men who don't have a diagnosis. What about patients with early disease? The most relevant question, or the question which comes up most often, is the setting of active surveillance. Should we offer these patients active surveillance if they are BRCA2 mutation carriers? And actually, there's no real consensus on that. The EAU did a study on that, a consensus statement about active surveillance. And when coming to the question if men known to carry the BRCA2 mutation are eligible for active surveillance, there was actually no consensus. Answers were all over the place. So at the moment, we don't know. There's one study from Johns Hopkins University, which is really often cited, which has shown that active surveillance patients with BRCA2 mutations are more likely to have a grade reclassification in the course of their disease. So their risk is higher, but one has to point out that this study only included 26 patients with BRCA mutations. So very small numbers, no real answer for that.
Thank you very much. Well, I think that brings us to a conclusion. I'd like to thank the panel for their input. And I would just like to point out that eCancer has produced a series of animations on this topic, and the links will be attached to the end of this video. Thank you very much.